I'm David Brown, Director of the Virginia Department of Health Professions. Welcome to Virginia's core competency modules for pain management and addiction. These competencies were developed by work groups convened by Virginia's Secretary of Health. Over 24 experts in pain management and addiction compiled the essential competencies that Virginia's health professional students must acquire, not just our future physicians, nurses, dentists, and pharmacists, but the wide range of professionals who work with these types of patients. These modules, made possible by a Department of Behavioral Health and Developmental Services grant, present key parts of the competencies for use not only by our schools, but by practitioners already in the field. Thank you for your careful attention to this important information.
Hello, and thank you for joining us in Module 3, Topic 3, Addiction and Primary Care. My name is Stephanie Peglow. I'm an addiction psychiatrist at Eastern Virginia Medical School, and I'm the Centera Systems Director in Addiction Treatment. I am board certified in addiction psychiatry, adult psychiatry, and addiction medicine, and my interest in research is around health policy and addictions and disparities in opiate use disorder treatment. Our lecture has 3 objectives today. Hopefully by the end of this segment, you will be able to identify practice-appropriate screening tools, including comorbidity screening. You will be able to summarize the continuum of care in addiction treatment, and I hope we have introduced you to ideas and resources at the end so that you will feel comfortable making a timely and appropriate referral for addiction treatment. So our first objective, practice-appropriate tools. If you're wondering, why screen for substance use disorders? We have national recommendations for screening. The Institute of Medicine has recommended that questions about alcohol use be included among routine behavioral and lifestyle questions asked of all persons who seek care in a medical setting, just like questions about diet, exercise, and smoking. SAMHSA and the AMA recommend annual screening for drugs, alcohol, and tobacco in adolescents. But since many teens are not seen for yearly physical exams, they suggest screening with every health care contact. The mechanism we use for screening is called SBIRT, which stands for Screening, Brief Intervention, and Referral to Treatment. It is the gold standard for screening in primary care for substance use disorders. It is part of a well-described and validated program that has been used successfully in nearly all medical settings and by medical personnel of all training levels. SBIRT is a framework for quick interventions for persons with risky substance use all the way through to persons with severe substance use disorders. SBIRT is important because linking someone to treatment is crucial, and treatment does work. SBIRT has been used across all sorts of medical settings, and hence, any medical visit is an opportunity for an intervention. It allows for effective, timely referrals. Practitioners are reluctant to screen and intervene without training or a framework provided for them, like SBIRT. Also, SBIRT saves money and improves a patient's prognosis. SBIRT screening starts with the initial broad screening for risky use of drugs and alcohol. If positive, the practitioner moves to a more in-depth screening for each substance endorsed by the patient. Examples of screens are the Not a Quick screen, as seen above. It is a short one-question screener for risky alcohol use, tobacco use, and asks about misuse of licit substances as well as illicit substances. If a person answers yes to any of the following questions, further investigation is advised. The CAGE aid is commonly used 5-question tool used to screen for drug and alcohol use. It does not screen for tobacco use. If a person answers yes to 2 or more questions, a complete assessment is advised. It has sensitivities and specificities up to 77% and 85%, respectively. The Audit C is a simple 3-question screen for hazardous or harmful drinking that can stand alone or be incorporated into a general health history questionnaire. It is scored by points from 0 to 4 for each question. A score of 4 or more in men or 3 or more in women warrants further investigation. It is not screened for drug use or tobacco use. If the patient does not meet the threshold in whichever screener you use, the screening is complete. Reinforce low-risk alcohol use and abstinence from drugs and alcohol. We will use the NIDA quick screen for demonstration purposes. If the patient says yes to 1 or more days of heavy drinking, note that the patient is an at-risk drinker. At this point, screen for alcohol use disorders with a more in-depth screener. For more information, please see the NIAAA website, How to Help Patients Who Drink Too Much, a Clinical Approach. This is listed in the resources. Audit, or Alcohol Use Disorders Identification Test, is a 10-item questionnaire that can be administered by a paraprofessional to screen for hazardous or harmful alcohol consumption. This screener correctly identifies 95% of people with an alcohol use disorder. The audit has been used with a variety of populations and cultural groups. A portion of the audit is represented here. If a patient says yes to use of tobacco, any current tobacco use places a patient at risk. Advise all tobacco users to quit. All use of tobacco is considered risky. At this point, consider an intervention to help a patient stop use of tobacco. A framework for this is the 5 A's. First, ask the patient about smoking behavior. Second, advise the patient to quit. Third, assess their readiness to quit. If they are ready to quit, provide brief counseling and resources. If not, encourage them to quit with a personalized motivational message. More on this later. Lastly, arrange for the next step and follow up with their tobacco use frequently. For more information on smoking cessation, please see Helping Smokers Quit, a guide for clinicians, in the resources section. If the patient says yes to use of illegal drugs or prescription drugs for non-medical reasons, proceed to the NIDA Modified Assist or DAST drug abuse screening test. For demonstration purposes, I have part of the drug abuse screening test or DAST 20 represented in this image. This has both adult and adolescent versions. Alternatively, you can use the CRAFT, C-R-A-F-F-T, for adolescents. The DAST also has a 10-question version. If the patient screens positive on any of the above in-depth screeners for tobacco, alcohol, or drug use, move to the brief intervention part of SBIRT. A framework for the brief intervention is a brief negotiated interview. The first step is to raise the subject. When you raise the subject, you want to make sure you have established rapport. You want to understand the patient's concerns and circumstance, explain your role and concern, and avoid a judgmental stance. Then raise the subject. For example, "Hello, I am Dr. Peglow. Would you mind taking a few minutes to talk with me about your opioid use?" If they don't want to talk about it, you might say, "Okay, I see you aren't ready to talk about this today. Remember that we are here 24/7 if you change your mind." If they are willing to talk about it, move to step 2, provide feedback. Compare their use to national norms. For example, frequency of use norms, binge norms, their personalized risk factors, potential or already realized negative consequences of use, or their symptoms of a substance use disorder. In step 3, we then seek to enhance motivation. We want to elicit change talk. For example, "I could use that money to buy a car," or "I want to have a job again." We want to assess them for readiness to change. Using the readiness ruler, we can show them the ruler or ask, on a scale of 1 to 10, 1 being not ready and 10 being very ready, how ready are you to change any aspect of your drinking patterns? Then we can use a response to enhance motivation. For example, if the patient indicates they were 2 or greater, why did you choose that number and not a lower one? What are some reasons that you are thinking about changing? If they say they are 1 or less, have you ever done anything that you wish you hadn't done when you were drinking or using drugs? Or, what would make using drugs or alcohol in this way a problem for you? Then discuss pros and cons of continued use. On step 3, we enhance motivation. We check for patient awareness of the situation. Point out discrepancies between present behavior and important goals as change motivators. Let the patient name the problem and the pros and cons. Don't use shame or blame in this process. Preach, stereotype, confront, or label the patient. In addition, avoid argumentation. It is counterproductive. Defending use breeds defensiveness and will make the topic that much harder to broach in the future, if the patient ever chooses to be truthful about their use with you again. Perceptions can be shifted, but not by arguing, and it may take time. Resistance by the patient is a signal for you to change your strategy. Roll with their resistance rather than become the wall they bang the resistance up against. If your patient is still working with you and considering some change, use step 4 of the brief negotiated interview. Negotiate and advise. Elicit a response. For example, how does this all sound to you? Then negotiate a shared goal. For example, what would you like to do? Give advice if needed. And lastly, summarize. This is what I heard you say. Thank you. Provide follow-up and referral. If you determine the patient is not ready for change, present feedback and concerns, if permitted. You can consider negotiation if the patient tolerates. For example, what would it take for you to consider a change? Lastly, if no change is negotiated in that contact, offer information, support, and further contact. When approaching any substance use, recognize your own assumptions before the conversation, as it will impede the work you do with someone. For example, dangerous assumptions can be, this person ought to change. This person is ready to change. The person's health is a prime motivating factor for them. If they decide not to change, the brief negotiated interview has failed. The patients are either motivated or not. We saw this on the change ruler. Readiness is on a continuum, and we can change moment to moment. Now is the right time to change. A tough approach is best. Or, I am the expert and they should follow my advice. For your referral, consider Virginia available resources. Several cities have warm lines staffed for patients with substance use disorders that connects them to a peer counselor for the purpose of enhancing motivation, linking them to treatment, and following up. Check your local community services board for the availability of a local warm line, as well as their substance use disorder treatment capabilities. You can also refer to the Virginia-specific treatment locator by drugsfreeva.org called Grab a Life Ring. Or outside of Virginia, text SAMHSA's website at findtreatmentsamhsa.gov or call 1-800-662-HELP. Our second objective is to summarize a continuum of care in addiction treatment. The continuum of care can be defined both at the personal level process of recovery and at the system level of treatment settings. A person's process of recovery is seldom depicted by a straight line. As with any disease, it has a relapsing and remitting course, and often someone takes several attempts to make a lasting change. Consider your last diet, for example. This is important to understand, as you see the patient may have a relapse. It is important to frame the relapse as a process of recovery rather than a failure. This helps the patient visualize their relapse as an obstacle rather than a wall and try recovery again. At the system level of care and the continuum of care applies to all different levels of treatment intensity. In considering appropriate referral, the most important question is, does the patient need acute, medically managed detoxification services? American Society of Addiction Medicine, or ASAM, created 2 levels for detoxification: hospital or outpatient setting. Consider referral to acute medical setting, i.e. admission to a hospital, if the patient is experiencing signs and symptoms of severe withdrawal or there is evidence that severe withdrawal is imminent. That being said, Withdrawal often does not require acute medical admission. Withdrawal from most substances is not life-threatening, with the exception of alcohol, benzodiazepines, and barbiturates, and nearly all other substances can be detoxified in a lower intensity setting, including opioids. The American Society of Addiction Medicine has established 5 main levels in a continuum of care for substance use disorder treatment. We will briefly explore all 5 levels. Level 0.5, Early Intervention for Adults and Adolescents, targets those at risk of developing substance-related problems. That's called primary prevention, or those not yet diagnosed, otherwise known as secondary prevention. Examples include SBIRT, one-to-one counseling with at-risk individuals, motivational interviews, educational programs for groups such as DUI offenders, and other populations at risk, for example, employee programs, drug-free workplace initiatives. These can be provided in nearly any setting, for example, at work, school, community centers, medical settings, or individuals' homes. In Level 1.0, or outpatient services, treatment occurs in health clinics and includes levels of care like OBOTs, or outpatient-based opioid treatments, or OTP, opiate treatment programs, otherwise known as methadone programs. This level of care is appropriate for people committed to recovery and for those with a high level of motivation. It may also be used as a step down from more intense levels of care. In Level 2, intensive outpatient programs and partial hospitalization programs, a patient blends learning skills and knowledge in a semi-structured program with practice in a real-world setting. This can occur in several settings, for example, health clinics, shelters, religious organizations, and the 2 levels are only distinguished by the number of hours of structured programming offered. Contrary to its name, partial hospitalization does not involve hospitalization. In fact, either level may provide unmonitored housing, but most don't. This level is appropriate for people with either variable level of engagement or ambivalence, and/or high risk of relapse, and/or non-supportive recovery environment, but they can cope. In Level 3, residential inpatient services, organized treatment services are offered in a 24-hour residential setting and are staffed 24 hours a day. These are considered community-based, but may be physically housed in a hospital. These sublevels are defined by intensity of care, not hours of structured programming offered. Subject to increasing pressure, access to residential treatment is less accessible, including in the Commonwealth. Appropriate for people with little awareness and blah, blah, blah. I'm going to read this again. This level is appropriate for people with little awareness and those that need structure, and/or people with little recognition or need structure to prevent relapse, and/or those where their recovery environment is dangerous. In medically managed intensive inpatient service settings, Level 4, patients are seen in the acute care inpatient setting. This level of care is only appropriate for people with high risk of withdrawal or unstable medical conditions or unstable psychiatric conditions. The most important objective is last, you feeling comfortable making a timely and appropriate referral for addiction treatment. Just like treatment of any other disease, treatment of addiction can be challenging to someone who feels unprepared or untrained. That is why I highly suggest you make use of the Virginia Opioid Addiction Echo. Any person involved in a patient's care with suspected opioid use disorder may utilize this twice-monthly interdisciplinary addiction team to ask questions about anything, including things like the ASAM levels of care. This team is aware of statewide and national treatment resources, standards of care, and can help you care for your patient. Lastly, there's incentive for changing your practice to include SBIRT. Bill for your hard work. You are worth it. If you performed the pre-screen and it was negative, this is considered an integral part of routine preventative care and it is not reimbursable. If it was positive and you moved onto a full screen, you can bill. If the full screen was negative, a billing code of H0049 could be used. For a positive full screen and brief intervention and/or referral, you can bill based on your time. 99408 is for 15 to 30 minutes of your time, and a 99409 is for more than 30 minutes. For further information, including several training manuals and great videos, check out these resources. I recommend them all. All of the drug, alcohol, and tobacco screeners pictured in this presentation are public domain. Those mentioned but not pictured are all free for to use clinically without payment. I've listed the web resources for all of them here. Thank you so much for your time and attention. Your patients need you. Go get them into treatment.